Okay. Greetings and a warm welcome to all the dignitaries present here. I am Shwastika from Team Clarnet, serving as an allocation assistant to ensure a seamless experience. Clarnet proudly stands as India's most relied upon digital platform, offering a multitude of imaging services exclusively for doctors. It is with great pride that Clarnet serves as a digital partner for this event. And the focus of today's session is USGRA lower limb. And now I would like to invite Dr. L. Meenakshi Sundaram sir, a distinguished anesthesiologist and academic leader. Sir has served as Dean and DME at several government medical colleges, including Theni and Stanley Medical College, Chennai. He is a former National Vice President of Indian Society of Anesthesiologists and has held key positions including Governing Council member, President, and State Secretary of the ISA Tamil Nadu State Branch. Now, sir, we can proceed the session. Over to you, sir.
Thank you, Clarinet. At the outset, I request our President, Dr. Munian, to offer his address.
Good evening, all. Dr. K. Munian, ISA President of Puthukkottai City Branch. On behalf of ISA City Branch Puthukkottai, I welcome our academic chairman, Dr. Meenakshi Sundaram, our moderator, speakers, and faculties for the online webinar conducted by ISA Puthukkottai City Branch in the name of Puthukkottai Bhudhan. Today, we are conducting 23rd episode of second edition of ISA Puthukkottai. Today, we are going to talk about the ultrasound-guided regional anesthesia for lower limb surgeries. What are the ultrasound-guided nerve blocks for lower limbs? It is a revolutionized pain management. Here's some overview of ultrasound-guided nerve blocks. What are the benefits of ultrasound-guided nerve blocks, which provides effective analgesia, reduced opioid consumption, and shorter hospital stay, improves patient satisfaction, and better functional outcomes. What are the nerves we are going to block? Femoral nerves, which are used for surgeries below the knee, surgery used for knee surgery. Femoral nerve blocks commonly encountered for knee surgeries, hip fractures, and thigh procedures. Sciatic nerve blocks, it is useful for surgeries in the posterior thigh, leg, and foot. Lateral femoropotaneous nerve block, saphenous nerve block, and popliteal nerve blocks are used for lower limb surgeries. Angle blocks, here we are going to block 5 nerves, saphenous nerves, and superficial peroneal, deep peroneal, and posterior tibial nerve, and sural nerves. We have to understand the ultrasound techniques for ultrasound guided nerve blocks for lower limbs. Here we are using high frequency linear probe for superficial structures and low frequency curvilinear probe for deep structures. And we also understand the real-time ultrasound guidance allows for the precise needle placement and local anesthetic spread. What are the key considerations for ultrasound guided nerve blocks? Understanding the ultrasound principles and good hand-eye coordination are essentials. Proper positioning and probe handling techniques are crucial. And also we have to understand that local anesthetic volume and spread should be carefully monitored to avoid local anesthetic systemic toxicity. So our speakers are interested to share their experience with all of us. Today we are going to listen to the online webinar. Let's listen in the webinar. Once again, thank you all. Thank you, sir.
Thank you, President. Now I request our Secretary, Dr. Kannan, to give his report.
Good evening all. I am Dr. Kannan, Secretary, ASA Puthukkottai City Branch. Successfully, we are conducting 23rd webinar of second edition of Puthukkottai Bhudhan today. I welcome all our eminent speakers to our webinar. Last week, we have conducted 22nd webinar successfully on 18th June. Last week, our topic was pre-eclampsia and update. We have divided the topic into 3 subtopics. First one is physiology of PH. Second one is pre-operative assessment of PH. Third one is anesthetic management of PH. Our moderator was Dr. Kajal Jain, Professor and HOD, PMR. First subtopic, physiology of PH, was done by Dr. Abhirami, postgraduate, Christian Medical College, Vellore, Tamil Nadu. Second subtopic, pre-operative assessment of PH done by Dr. Meghna, Professor, Christian Medical College, Vellore, Tamil Nadu. Third subtopic, anesthetic management of PH done by Dr. Ekta Rai, Professor and HOD, Christian Medical College, Vellore, Tamil Nadu. Around 755 delegates have attended our webinar. And one more thing I would like to say is our academic chairman, our mentor, our well-wisher, Dr. AL.Meenakshi sir is going to contest in President-elect ISA 2025 election. Moreover, other than our academic chairman's academic activities, sir has done several social service activities. NABH accreditation for a government medical college, first in the history in India, and he has mobilized a Flag Day Fund for Indian Army in 2016. He has got a silver medal and appreciation from our Chief Secretary Tamil Nadu, and 2017 5.65 lakhs for he has got a gold medal and appreciation from our governor of Tamil Nadu. In 2018, he has done 5.15 lakhs. He has got gold medal for that and appreciation from our governor of Tamil Nadu. He has arranged a medical camp in his village in Tamil Nadu, inaugurated by our State Minister of Law in Tamil Nadu. Modernization of government primary school of the tune of 1.5 lakhs. He has donated 1 lakh 11,111 to Varanasi Shiva temple, and he has donated 1,11,111 to Palani Murugan temple. Please support our academic chairman to win the election. Thank you, sir. Thank you all.
Thank you, Secretary, for including me also in your report, because he is a well-wisher. And now it is my duty to introduce the faculty to the delegates. So the youngest faculty, Dr. Goutham Reddy. Just because his name is Reddy, don't think that he is from Andhra. He is from Bangalore, and he is a AORA fellow, and he is doing it in Apollo Hospitals, Bangalore. In addition to his routine academic activities, he is a runner. So he will not run away from the scene when a crisis comes. He will run to the scene when the crisis comes. That is his specialty, and he has participated in few half marathons. So he is halfway through in participating in a full marathon. He is going to do that. We wish him that he does that full marathon. So he is reading. He is reading not only anesthesiology, but also novels, science fiction, everything. And I hope usually we have a tea taster. That is to test the quality of tea. We will have tea tasters, but this man is a coffee taster. I think he is tasting different kinds of coffee. But boss, I want to tell you, coffee is dangerous than tea to the health. So just a taste, don't drink. Okay. So I wish him all the success. It will be the second faculty will be our Tamil Nadu person, because today we have a pan-India participation of the faculties, because one from UP, another from Karnataka, and one from Tamil Nadu. So this is a pan-India. Out of our 72 episodes, this is the 6th time it is happening at the pan-India, and we thank Dr. Murali for arranging this wonderful combination of people. This Dr. Archana is from Coimbatore. She is working in KMCH, Kovai Medical Center actually. So she is very fond of regional anesthesia more than her family. So she has presented award papers in so many national and international conferences at her young age. That is the point to note. And she has done this. She is a AORA Indian Executive Committee member. And she is a member in Board of Studies also, National AORA Fellowship Program. That means even though she is popular across the country, she is interested in regional anesthesia, but her skills are not restricted to Tamil Nadu region. It is extending throughout the country and also the international arena. And naturally, she is interested in ultrasound guided regional anesthesia and research and training in regional anesthesia. See, now you have to note, she has achieved everything. And this dynamic young lady is waiting for her life partner. And this matrimony, now this Puthukkottai Bhudhan has become a matrimony, and madam is there, and she is a eligible person. So she will be followed by Dr. Amrita Rath. If at all we want to talk about Amrita Rath, it will take a day. She is such a popular person. So she is a European diplomat. She is a European diplomat, and she is a fellow College of Ireland. These are all the names we have read only in books. But really, these Indians made us really proud, because the skill is to be respected internationally. They have proved that. And she is a European diplomat of anesthesiology and critical care, UK. She is a postdoctoral fellow in pediatric and neonatal anesthesia. That is also a point to note. And more than that, even from the student days, she is a gold medalist in postgraduate program. She is a gold medalist in PG exam. And she has won the Wonder Woman Award in Banaras Hindu University. So necessarily she is a wonderful woman. Hope the 7 wonders of world, she may become one wonder in future days to come. And she has several publications to her credit. And in addition to everything, she is interested in painting and traveling and baking. Necessarily she has to travel. And our Archana is also good at cooking. So her food is tasted by entire department, Kovai Medical Center. So that is a good point to ponder over. So she is more eligible as she is a good cook. So these people, in spite of being academically sound, they are concentrating on extracurricular activities also. So to control this gold medalist and the younger scientist, dynamic person, we have to have a good moderator, or else it is very difficult. And a good moderator to introduce Amrita Rath will take 1 day, and to introduce the moderator it will take 1 year. So I cannot do all those things. But see, actually, he is a FRCA graduate. That itself will say, Indian, necessarily we will respect the foreign countries. And now he has been awarded FRCA, and he is a fellow of pain medicine. That is also one point in UK. So he is from FRCA as well as pain medicine. And even though he got that degree from foreign country, he is a social media editor for our IJA. If you see the infographics or these interviews, if suppose a foreigner is coming here, and if he is to be interviewed, it can be done only with Murali. No other person can do that because of his accent. You see any one of the interview, you listen, the way in which he talks, see, everybody will be spellbound. Such a wonderful vocabulary and a mesmerizing voice he has. Necessarily, he is a distinguished clinical tutor in Apollo Hospital. And more than that, now he is, but he was a specialist registrar in Norwich, Norfolk, Suffolk. Even I pronounce it wrongly, nobody can understand, because we have never seen all these places. But he is from a foreign country. Occasionally, he will be available in India. So at that time only we are using this. Occasionally he will be available. So we have utilized that opportunity. He is a president-elect for Karnataka Society, ISSP, actually, Indian Society for Study of Pain. He was a president-elect for Karnataka. He was an honorary secretary for ISSP, and he was organizing secretary of ISSP National Conference. And necessarily, madam is a gold medalist in PG, but Murali is a gold medalist in undergraduate days itself. He has won gold medal in physiology and ophthalmology. So, madam, you are at the PG level, Amrita, madam, but Dr. Murali is from UG level. So, he has won the Hall of Fame award in Ganga Hospital. So, I'm also happy in saying that, because they have given to me also. So, at least in that level, I'm equaling Murali. So, I'm very happy about that. So he has written numerous articles. If it have minimum 30 internationally and more than 100 in India, that is common for him. So for every month he will be writing one article in that. But he has written 5 book chapters in Essentials of Life Safe Anesthesia. He has written 5 book chapters. So quality assurance management also he has given a book chapter. And anesthesia challenges in COVID-19 and mucormycosis. So he has done that. And in textbook of pain, he has given 2 chapters. So it is countless. It is countless. Usually the pages of a book will be countless, but his achievements are countless. And he is a faculty throughout the world. So if I say I have to enumerate the entire universe, because he has participated in Singapore, Paris, Philippines, Manila, everywhere he has participated. But in addition to everything, he is a technocrat. Necessarily, that is the reason why he is living in Bangalore. He is a IT technocrat. So he has formed a mobile app actually. It is used for AORA people. It is named as AORA for you. Even I was wondering that for is they will written 4. That number will be written as 4. That is what we write. UR means we will put a U and R in SMS. That is how he has used the terminology AORA for you. Because CU we will put alphabet C. Like that he has devised that where you can inform everything, including the critical events. So that is handy. He is even developing that. He is a voracious writer. He is a voracious reader. So that is the reason why even in the background, so a lot of his books are there. Background books are there. The contents are in his mind. So that is the difference. He is just showing us what to read. And in spite of all these things, he is a good swimmer. So anesthesiology is swimming. Whether you opt butterfly or a breaststroke or a reverse stroke, you have to reach the shore safely. So he is an anesthesiologist, a good swimmer. So he can even swim against the tides and against all the odds, and he will reach the shore safely with the patient. That is the credit of Dr. Murali. And he calls himself as an amateur photographer. But his photographer, you see, his Insta page. So he is having a block also. So that and all, it is very difficult to imagine. But everything Murali has brought into his life. So he is a model for all the anesthesiologists, not only anesthesiologists, all the doctors across the country. Everyone should emulate him. And now, with my best wishes, I hand over the session to Dr. Murali, please.
Well, thanks a lot. I mean to say that introduction, I've never had that kind of introduction ever. And I'm sure it goes same with Archana and Amrita. So both of them are blushing. In fact, I can see that. Now, talking about the entire program, it is just amazing that you've been conducting such a wonderful program with the Puthukkottai ISA branch. And I see your messages that each of the session is attended by more than 700, 800 people, which is just amazing. The amount of work that is being done. And thank you for giving us an opportunity today to speak about something that all of us are passionate about as a part of Academy of Regional Anesthesia. As you rightly mentioned, Archana is a part of the Board of Studies, one of the key people when it comes to the future of teaching in regional anesthesia in the country. And Amrita has been quite actively participating in workshops across the country. She reaches every part of India, trying to teach both pediatric and regional anesthesia. And of course, as you said, Goutham is a fellow in our institute and a very promising person, and also a part of our IJI podcast team. So what we will do in the next 1 hour, 10 minutes is we will go through the important aspects of lower limb when it comes to regional anesthesia. So Goutham will take us through the basics of what are the various aspects of anatomy and innervation and why it's important to understand that. And following which Dr. Amrita and Dr. Archana will take us through the specific nerve blocks that are required and how it's going to help in intra-op and post-operative anesthesia and analgesia. So I think I will hand over the mic to Dr. Goutham. And in the meanwhile, I request everybody who's listening to this to kindly share their questions or their views in the chat box, which I will take later with the speakers. So over to you, Goutham. Thank you.
Thank you, sir. Okay, good evening all. And first of all, I would like to thank Dr. Meenakshi Sundaram and the entire ISA Puthukkottai city branch for this opportunity. I'm really grateful, and thank you to Dr. Murali also to help me guide me through the whole session and helping us do this particular session. So today I'll be quite brief. It'll be about 20 minutes, my session, and it'll be on pain generators of the lower limb. The learning objectives here, what I'll be talking about is nerve supply of the lower limb, mainly focusing on the hip joint and the knee joint, the anatomy pertaining to this, pain generators of the hip and knee, which will be the crux of my talk, and relevant regional anesthesia techniques, which I'll be covering in brief as the other two talks are mainly going to be on this. Okay, first coming to the nerve supply of the lower limb. So unlike the upper limb, the lower limb is innervated by two distinct plexi. One is the lumbar plexus and the second being the sacral plexus. The lumbar plexus, it's formed by the L1 to L4 anterior rami. They have terminal branches of femoral nerve, obturator nerve, the lateral femoral cutaneous nerve, and accessory obturator nerve, which is present in about 30% of the population, the iliohypogastric nerve, ilioinguinal nerve, and the genitofemoral nerve. The sacral plexus arises from the anterior rami of S1 to S4. This gives off the sciatic nerve, the superior gluteal, the inferior gluteal nerve, posterior cutaneous nerves of the thigh, and the pudendal nerve. So just briefly about some definitions. So dermatomes, it's the skin area supplied by the dorsal root, the sensory part of the spinal nerve. The myotomes would be the skeletal muscle segment innervated by the ventral motor root, and osteotomes are innervations of the bone via the articular branches. So here we can focus our attention. Here on the left side would be a dermatomal or a cutaneous sensory distribution. But mainly I would like to talk about what the image is on the right side, the osseous sensory distribution. So focusing on the hip joint and the knee joint. As you can see on the anterior aspect of the hip joint, mainly we are focusing on the femoral innervation of the anterior aspect of the hip joint along with the obturator. And if you see the posterior aspect, it also gets covered by the sacral plexus. And in the knee joint, the anterior aspect again by the femoral nerve and components of the femoral nerve, and posteriorly by the components of the sciatic nerve in the knee joint. Just for completion's sake, this is the muscular sensory distribution of the lower limb. So coming first to the hip joint anatomy. So hip joint is a ball and socket type of synovial joint between the femoral head and the acetabulum. The acetabulum is formed by the ilium, ischium, and the pubis, and it's deepened by the acetabular labrum. So the acetabular labrum is a ring around the acetabulum, which this forms around the acetabulum, which has a relatively high density of nociceptors, and we'll be covering a lot of this in the following slides. It is stabilized by ligaments, the iliofemoral, pubofemoral, ischio-femoral, and the muscles of the hip. The major nerves supplying the hip are the femoral in the anterior aspect, the obturator in the medial aspect, and the sciatic in the posterior aspect. So the anatomy of the hip here, what we can see is the capsule, and it contains majority of the pain generators of the hip joint. And if we take off the capsule, what we can see is the femoral head and the acetabulum of the hip, which also contains some of the nociceptors present in the hip joint. So pain in the hip joint, this is a hallmark symptom of osteoarthritis of the hip. It is commonly presented as pain in the groin, anterior thigh, or the anterior knee. This is a referred pain. So there are two theories which describe reasons for this referred pain. One is the convergent projection theory and the other is an axon reflex theory. Just briefly about this, the convergent projection theory states that somatic and visceral fibers converge on one dorsal neuron. And in the axon reflex theory, the primary afferent fibers bifurcate and then supply somatic and visceral structures. Nociceptors, what we will see here are free nerve endings responding to harmful stimuli. So they can be carried through A delta fibers, which carry sharp and fast pain, and C fibers, which carry a slow or dull aching type of pain. The signals travel through the dorsal horn, then ascend via the spinothalamic tract and then to the cortex as we perceive the pain. Hip joints contain mechanoreceptors, polymodal, and silent nociceptors. So the type of receptors what we see are the mechanoreceptors, which contain the Ruffini, Pacinian, and the Golgi corpuscles. and the nociceptors, which are the free nerve endings. So the crux of my talk being pain generators of the lower limbs, this is where I would like you to focus your main attention. The innervation of the anterior hip capsule. So the highest density of the mechanoreceptors is present in the superior lateral portion of the anterior hip capsule and poorest in the inferomedial. The highest density of the nociceptors in the center of the superiormost aspect of the anterior capsule, and deeper layers tend to have more nociceptors than the superficial layers. The innervation of the anterior hip capsule, the nerves which supply it are the femoral, obturator, and accessory obturator nerve, which is again present only in 30% of the population. So just focus your attention on the left side of the screen. So this is the anterior hip capsule. And what you see in the green color, this is where the density of the mechanoreceptor lies. The darker green color, so your anterior superior part of the hip capsule is where your majority of the mechanoreceptors are. And superiorly here, what you see in the red color, that is where the majority density of the nociceptors are present. Innervation of the posterior hip capsule. Here, the highest density of the mechanoreceptors is in the posterior lateral portion of the posterior capsule, and the nociceptors are found quite sparsely distributed throughout the posterior capsule. Posterior capsule is supplied by the sacral plexus branches, which is the nerve to the quadratus femoris, which supplies the posterior medial capsule, the superior gluteal nerve, which supplies the posterior lateral capsule, and sciatic nerve indirectly contributes via the articular branches. So the image on the right side is of the posterior hip. As you can see, there is no red color depicting the nociceptors here, as they're quite sparsely distributed, but there are mechanoreceptors distributed throughout the posterior hip capsule. So in this difference, you can see why blocking, using regional anesthesia to block the anterior hip capsule becomes more important. Again, another table to describe the mechanoreceptor and the nociceptor distribution. So as we spoke about, the mechanoreceptor distribution is there both on the anterior and the posterior capsule, but the nociceptor, as you can see, is mainly on the anterior capsule of the hip joint. Coming to the innervation of the labrum, the anterior superior part of the labrum has the highest density of the mechanoreceptors here. The high density also reported in the posterior superior, inferior, and the antero-inferior labrum. Nociceptors, here the highest density is in the superior labrum, followed by the inferior labrum, and density decreases radially from periphery to the central portion. So this is the image of the labrum and the density of the mechanoreceptors on the left side, and the density of the nociceptors on the right side in the red. So the darker structures are the higher density and the lighter structures are lower density. So articular branches and nociceptors. Here the articular branches carry nociceptors to the hip capsule. Anterior capsule and the labrum, as we spoke about, have the highest nociceptor density. The femoral obturator superior gluteal nerves provide these branches. These are the target regions for pain control in regional anesthesia. So what are the regional anesthesia techniques for hip? So we can perform a fascia iliaca block. Here a high volume would cover the femoral as well as the obturator nerves, although the obturator nerves can be missed in this block. A PENG block can be performed where it targets the femoral, obturator, and accessory obturator articular branches of the anterior capsule of the hip. Both provide effective anterior hip analgesia. The PENG is a motor sparing type of block, whereas the fascia iliaca block is more widespread. What is the clinical relevance? So in hip fracture, regional anesthesia blocks could be better than opioids for pain and comfort. It reduces respiratory depression, delirium in the elderly. And in total hip arthroplasties, blocks reduce postoperative pain and opioid use, enable faster rehabilitation and mobilization. Risks and contraindications for nerve blocks. The contraindications, of course, are infections, anticoagulations, and patient refusal. The risks involve nerve injury, hematoma, LA toxicity, and motor block. Ultrasound guidance reduces these complications, and we need to balance benefit versus risk in each case. Next, moving on to the knee joint. So knee joint anatomy, it's a synovial type of hinge joint. It's composed of the femur, tibia, and the patella. The articulations are tibiofemoral and patellofemoral. The key ligaments involved here are the anterior cruciate ligament, posterior cruciate ligament, medial collateral ligament, and the lateral collateral ligament. The menisci, patella, capsule, and quadriceps tendon stabilize and aid in the movement. An image of the knee with all the ligaments. So here focusing on the nerve generator, pain generators again. In the anterior innervation, it's by the femoral nerve, L2 to L4, anterior capsule via the vastus medialis branch of the femoral nerve. The saphenous nerve covers again the medial knee and infrapatellar area. And it is important in anterior knee pain, especially post-surgery in TKR patients. The posterior innervation, the sciatic nerve splits into the tibial and common peroneal, and mainly the tibial nerve provides innervation to the posterior capsule, the PCL, and the menisci. It supplies nociceptors for posterior knee pain. The medial and lateral innervation, the obturator nerve covers the medial joint capsule, the common peroneal nerve, the lateral genicular branches, and the lateral femoral cutaneous nerve over the skin over the lateral thigh and knee. Articular branches from the muscles supply the joint capsule. High nociceptor density is seen in the reticula. The reticula is basically the quadriceps tendon covering on either side of the patella. And the fat pad here is the infrapatellar fat pad, which has high nociceptor density, and another one being the cruciate ligaments. The painful zones include the meniscal horns and the ligament insertions. So in this image, what you can see, the image A on top is the dermatomal innervation, anteriorly mainly supplied by the femoral nerve and the saphenous nerve, posteriorly by the posterior cutaneous nerve of thigh and the sural nerve. In the osteotomal innervation, what we can see here is the saphenous nerve mainly covers the anterior medial thigh, and the common peroneal nerve, the anterior lateral part of the thigh. And one of the most important things here is the capsular innervation, which is seen at the bottom image here, image C. So capsular innervation is by multiple nerves and its branches. So if we can focus our attention first on the anterior knee aspect. So superior medially, it is innervated by the nerve to the vastus intermedius, the nerve to vastus medialis, and the superomedial genicular nerve. And inferiorly, the infromedial genicular nerve. And laterally, what we can see here is nerve to vastus intermedius and nerve to vastus lateralis, superior lateral genicular nerve, and the common peroneal nerve. And inferiorly, the inferolateral genicular nerve and the recurrent fibular nerve. Posteriorly, it is covered medially by the tibial nerve and the posterior division of the obturator nerve, and laterally by the tibial nerve and the common peroneal nerve. So what are the regional anesthesia techniques here? We can use a femoral nerve block to provide anterior analgesia, but the drawback is it causes quads weakness. So an adductor canal block is a motor sparing type of block to perform, which covers the saphenous nerve and is quite commonly used in patients undergoing TKR. The IPAC block is covering the popliteal plexus and provides analgesia to the posterior capsule. Genicular nerve blocks are used in chronic knee osteoarthritis pain relief. Clinical relevance here, the regional anesthesia reduces pain and opioid need and improves rehabilitation. For TKR patients, commonly an adductor canal block and an IPAC block is effective for analgesia with preserved quadriceps strength. In trauma, early femoral or adductor canal block improves patient comfort. So just to summarize on both the joints and its pain generators, for the hip joint, anterior capsule primary is its primarily nociceptive source is the anterior capsule by the femoral and obturator nerve. The posterior capsule via the sacral plexus. The fascia iliaca block and PENG are effective for hip fracture and surgery pain. And know your contraindications and apply these blocks safely. The summary for the knee joint, Knee nociception is via the femoral, tibial, peroneal, saphenous, and obturator nerve. So match your block to the pain location, anterior versus posterior. Use multimodal approach for surgery or trauma. And like I said, the adductor canal block and IPAC block have optimal coverage without motor loss. Thank you for your patient listening. Thank you.
Thank you, Gautam. Thank you. So you did a wonderful job of highlighting the main aspects where we need to think about when we think about hip and knee surgeries, which has nicely led on to our next speaker, Dr. Amrita. Considering we have an aging population across the world and there will be more of these replacements happening at both hip and knee joint, I think as anesthetists, we'll need to focus more in ensuring that the patients have a very safe anesthetic and a comfortable journey during their stay in the hospital. So to talk about the regional anesthesia strategies for a total hip and a total knee replacement, I'll hand over the mic to Dr. Amrita. Amrita, over to you.
Thank you, sir. Thank you. At the outset, I would really like to thank Meenakshi sir and Murali sir for giving me this opportunity on this esteemed platform. So for the next couple of minutes, I will be talking and taking you through the RA strategy for THR and TKR. So I bring you all greetings from the city of Lord Shiva, Kashi, and my alma mater, Banaras, in the university. I have no conflict of interest, but I just want to tell whatever Dr. Gautam has spoken, yet you can find few of the things repetition in my slides. However, as it is very important, if you know the anatomy, you know what the block you need to choose. So it's a repeated reinforcement that will help you to learn better. So first I will be taking you for the RA strategy for total hip replacement, and in the second portion I will be taking you through the knee replacement. So you see a young lady who has come with a chief complaint, I cannot move my leg and the pain is terrible. And what you see is she's an elderly lady and her right leg is already visibly shortened. So as the patient arrives in the emergency and the clock has actually started, her hip bone has fractured. So what the lady is talking to you, can you ensure I don't have pain now and then? What you are supposed to do as an anesthetist. So if you look at the total overview of hip replacement, there is kind of 4.5 lakhs elective surgery annually in India, and most of the common indication are arthritis, trauma, or avascular necrosis. Though we have always in the concept of multimodal analgesia, yet if you add regional analgesia to those, in addition to the MMA, it definitely improves the quality post surgery. So if you compare the intensity of the pain, this is published in BJ 2021, what they found was in the post-operative period, the VAS score was around 4 out of 10. That means the patient has reasonably pain even with simple multimodal analgesia. So why we need regional anesthesia along with MMA that has already been spoken to minimize the opioid space, to enhance the ERAS protocol, to have a targeted pain relief and definitely a better outcome. So if you say for this particular case and have to plan the analgesia for the hip conundrum, so what all factors I need to take into account? Age of the patient. As we already covered, the hip has a complex innervation. The type of fracture is also very important to think which block I need to give. And finally, the surgical heterogeneity and depends on your surgeon where you're working. So a brief anatomy of what has been already taught. So if you think the anatomy of the hip, it receives the branch from the lumbar plexus and the predominant from the femoral, the LFCN and the obturator. So these three nerves you need to take into account when you're planning your hip analgesia. So the analgesia of the hip was actually formulated from this first anatomical landmark study by Sort et al., where again they found the hip is predominantly innervated by the articular branch of the three nerves, which I have already spoken about. So briefly, the myotomal is by the femoral obturator and the posterior by the sciatic. The dermatomal is by the anterior cutaneous branch of the femoral nerve, obturator and iliohypogastric nerve. Why this is important, especially When the incision for the hip can be a bit like few surgeons do a anterolateral incision, few do a lateral, and few do a posterolateral. So type of the block for the dermatome will depend on the type of the incision. So this is why we need to know the dermatomal supply. Coming same as the myotomal is the osteotomal supply for the hip. So again, this is a repetition. So as we have already spoken, when you talk about the hip, predominantly we are concerned about the anterior capsule, which has the maximum number of nociceptors as compared to the posterior, which has more number of mechanoceptors. So if overall the summary is, if you want to focus, femoral is for all the quadrant, obturator is mainly the inferior quadrant, accessory obturator is for the medial quadrant. And for the posterior, the sciatic nerve, superior gluteal nerve, nerve to quadratus femoris. So 3 in the anterior, 3 in the posterior, you need to be careful about. But most overall, the most important thing is anterior hip bend because it has the maximum number of nociceptors. So you have a platter of options now. So if you ask what are the analgesia options I have, I can start from the neuraxial to periphery. And in the era of, as we are going to more eras and we are following a more motor sparing thing, so we are moving from neuraxial to periphery. So in the neuraxial, we have spinal. You can go for a continuous spinal or a single shot. You can add intrathecal morphine. So when you move to the anti-hap capsule, as we know, we need a femoral nerve block or a suprainguinal fascia iliaca or PENG. And for the posterior, again, you can have sciatic, nerve to quadratus femoris, and clonial nerves. So between the anterior and the post and the neuraxial approach, there are some few blocks which has been proven in studies as the posterior approaches like lumbar plexus. You have lumbar ESPs or anterior QLB. However, I will be restricting my talk to the most important because I know most of the viewers here are postgraduates to the most of the plan A blocks, plan A and maybe few of the plan B blocks. So first, as if you remember the scenario, the older lady has come to you in the ED and she asked you, what are the options? I have to be absolutely pain-free now and then. So what are the RA option do I have? So there is a concept of on-arrival block. So as soon as the lady comes to your ED, you can provide her a good pain relief so that she can further move to the radiological department or maybe further evaluation in absolutely pain relieved way. Second is, so what are the option you have depending on the nerves you want to block? You have femoral nerve, you have suprainguinal fascia iliaca, and you have PENG block, right? For the ease of the positioning, like you have seen, this is an elderly patient, and you know in elderly how difficult it is to give a subarachnoid block. So if you want a good position for your spinal anesthesia, you may need to make the patient pain-free. Again, what are the options you have? You can give a femoral nerve block plus a lateral femoral cutaneous nerve, a suprainguinal fascia iliaca, PENG, and LFCN. Again, I will be discussing each of the block. And the same in combination you can give for post-op analgesia as well. So, as a beginner, if you ask me what is your plan of block, I would say for plan A blocks, go for a femoral nerve block along with a lateral femoral cutaneous nerve. For the plan B, if particularly in setup where they need a fast track recovery, where they want an early ambulation, maybe just in some 4 to 8 hours. So there you can try a suprainguinal fascia iliaca or you can give a PENG plus LFCM. And plan C are the reserve block, which is not like only in few indicated cases it is tried, like lumbar plexus block, sacral plexus block. You can go for lumbar ESP and anterior QLB. So I will be focusing mainly on plan A blocks and I will be sailing a bit to the plan B blocks as well. So femoral nerve block. So femoral nerve block is formed by the dorsal divisions of the anterior primary rami of the spinal nerves L2 to L3-4. So if you look closely and you will appreciate, you will learn the anatomy. This is the head of the femur and I'm looking from anterior to posterior. So what you see here are the vessels, the femoral artery and the femoral vein. Next step, you have to appreciate the fascia, that is the fascia iliaca. And attached to the head of the femur lies the muscle, that is the iliopsoas. So here is an important concept that you have to learn. The femoral nerve lies in a separate compartment than the vessels, that is the artery and the vein. So if you look again, so the red structure that marked is the femoral artery, the blue one is the femoral nerve, and now you look at the lateral edge of the femoral artery. So what you see here is the green color line that is going is the fascia iliaca, and it bifurcates into two, and the triangular structure that is covered by the two layers of the fascia iliaca harbors the femoral nerve. So the yellow structure that appeared is the femoral nerve. So reverse on anatomy is on the right side. So if you see the femoral vessel, just right to it, beneath the fascia iliaca lies the femoral nerve. So vessel and the nerve lies in separate compartment. So again, just a repetition. So this is the femoral artery. So this is the iliopsoas muscle, which is attached to the head of the femur. And then the line, which is very superficial, a hyperechoic line, is your fascia lata. So down you can see the yellow color is your fascia iliaca, and fascia iliaca will split into two layers to harbor the femoral nerve. So the structure within the two layers of the fascia iliaca is the femoral nerve. So this femoral nerve is very much anisotropy in nature. That means by a bit of tilting or your probe cranial to caudal, you will appreciate the nerve better. So maybe at times when you keep perpendicular, you may not be able to appreciate the nerve so nicely, but when you tilt your probe, you do certain manipulation, you will appreciate the nerve which is harbored inside the two layers of the fascia iliaca. So before I start doing the nerve block, we need to learn few things that is mandatory for any block you do in regional anesthesia. So consent, the mnemonic of slim rack, and then stop before you block to avoid a wrong-sided block. This is a first slide, so I have just put it as in a number. So maybe in subsequent, I'm not going to have a repetition. And for those people who are new to regional anesthesia, there is a mnemonic called a slim rack, where S stands for strict asepsis, L stands for a light source, I for a IV access, M for a monitoring, R for a resuscitation drug, A for an assistant who is well trained, and GA for as a backup. And so you should have your trolley, your kit ready, then you plan your block. So while performing, so you can appreciate the patient will lie supine with the legs slightly externally rotated and abducted. As already we mentioned, this is a superficial block, so we need a linear probe, and the probe and the needling is done in plane from lateral to medial side. And the volume of the drug that I generally do in my clinical practice is 10 to 15 mL of 0.2% ropivacaine. So now you can appreciate the real-time needling. So you can appreciate the femoral artery. Here the fascia iliaca, which is split into two and harboring the femoral nerve. So the needle has come from lateral to medial, and I'm trying to pierce the fascia iliaca and inject the drug on the lateral edge of the femoral nerve. And I have to ensure that I do not do any intraneural injection. So after negative aspiration, you can give your drug, and you can see the femoral nerve being floating inside inside with the local anesthetic around it. So here you need not go very much medial to the artery. Even if you deposit the drug on the lateral edge of the femoral nerve, it will necessarily bathe the femoral nerve and effect will come out. So next, coming to the suprainguinal fascia iliaca. So first, again, as I mentioned, this is a plan B block. This will consistently block the femoral nerve and LFCN. Initially, the concept was infrainguinal, but they found that infrainguinal consistently block the femoral nerve, but it does not block the obturator LFCN. So they moved a bit more proximal. So now we are doing a suprainguinal fascia iliaca. But here again, just in 33% of the cases is block the obturator nerve. So predominantly it blocks the femoral and LFCN block. So this is a superficial block, so it can be given in patient with anticoagulants, but you have to ensure this is a very high volume block. So the important key points which you have to see, that you have to place your probe just medial to the anterior inferior iliac spine in longitudinal orientation, pointing towards the umbilicus. So as I already mentioned, it's a high volume block, so we need at least 30 to 40 mils. And since it is only for analgesia as a facial plane block, 0.2% of ropivacaine or 0.25% of bupivacaine will suffice. So once you place your probe just medial to the anterior-inferior iliac spine in a longitudinal fashion pointing towards the umbilicus, what exact picture you will see? You will appreciate the anterior-inferior iliac spine, the muscle which you already saw as the iliopsoas muscle. Then it is called as a classical bow tie appearance, where on the one side, on the cranial side of the screen, you will appreciate the internal oblique or the abdominal muscles. On the caudate side, you will appreciate the sartorius. And in between, you will see the two fascia joining looking like a bow tie. So once you see this, once you obtain this sonographic image, then you try to look at the deep circumflex femoral artery. So you will see a pulsatile structure on the pelvic side, that is towards the abdominal side, and just deep to the DCAIA, you have to deposit your drug. So this is the exact place where you deposit that drug. Again, high volume block. So you have to, after negative, you always need to aspirate because it's next to the artery, and then you can give your drug. So you can, this is the artery which I was talking about, and then you can put your drug. So next third, I will be talking about the pen block. So for the pen block, you first need to know a few points, that why the name pen, whether because it was first described by Philip Peng. So was it with the name of the scientist Peng, or it is a pericapsular nerve group block? So either way, both the things stands correct only. So here what you have to do is, first, the first point which you appreciate here is the anterior superior iliac spine. Second, the finger was pointing towards the anterior inferior iliac spine. And then the third point is the iliopectineal eminence. So what is the importance of knowing this is, the articular branch of the femoral and the obturator nerves, they are mainly concentrated in the region between the iliopubic eminence and the anterior inferior iliac spine. So we have to focus the particular area in this where you will find the maximum number of the articular branches of the two nerves. Here you have to note, lateral femoral cutaneous nerve will not be blocked and pen blocked. So just you have to place your probe above the inguinal ligament, and you have to focus on the place between the anterior inferior iliac spine and the iliopectineal eminence. Okay, so as you see here, it's a deeper block. So again, in the patient with anticoagulant or the patient on anticoagulants, it is a contraindication. So if you are trying it for a on arrival block, you need to be careful, as these are the elderly patient and they might be on anticoagulants. So in such cases, it is better to avoid pen block and go for a suprainguinal fascia iliaca. So here, when you place your probe just above the inguinal ligament, you have to appreciate the two bony structures, that is the lateral, the anterior inferior iliac spine, and medially the iliopubic eminence, and try to look just the bone connecting to this important landmarks on which lies the muscle, the psoas muscle, the psoas tendon and the iliacus muscle. So deep to the psoas tendon is the place, there is a small place where below the fascia where lies the articular branches of the two femoral and the obturator nerve. So our target is to deposit the drug there. So just a quick anatomy. So if you see the muscular relation, so this is the psoas muscle and this is the iliacus muscle. This is the anterior inferior iliac spine, and here is your iliopectineal eminence. So if you reflect the psoas muscle and the iliacus, they have purposefully removed these two muscles to show you the exact point where you need to deposit the drug. It is above the inguinal ligament and on the floor of the psoas tendon. So for this, if the patient need to be in supine position, you need a curvilinear probe. In very lean and thin individual, you can go for a linear probe as well. And here you can do the same in 3 simple steps. First, you have to draw an imaginary line joining the anterior superior iliac spine to the pubic tubercle, that is the inguinal ligament. Then you have to probe your probe in the transverse orientation above this line and identify the anterior superior iliac spine. As the finger was pointing, same as the probe direction will be. Then you move the probe towards medial, you will see the anterior inferior iliac spine, and further down you will see the iliopectineal eminence. And you have to focus the point between the anterior inferior iliac spine and the iliopectineal eminence. Look at the psoas tendon and the iliacus muscle. So this is exactly what I was talking about. So this is the lateral side. This is the right side, is the medial side. You will see the anterior inferior iliac spine, the iliopectineal eminence. The iliacus muscle lies your psoas tendon. So deep to the psoas tendon, between this line, you can deposit your drug. Though it is not given in any literature, but sometimes you can call it as a Salvador Dali mustache sign because it looks just like a mustache of Salvador Dali. So coming to the scanning phase, as you can see here, as I'm scanning down, I can appreciate the anterior superior iliac spine, further down the anterior inferior iliac spine, right? So as I'm going more medially, I can see with a bit of pivoting is needed to get the actual structure. So you will appreciate the psoas tendon, the iliacus muscle, the iliopectineal eminence, right? So where exactly to deposit the drug? So I have already mentioned this. Again, for this, you do an inline approach from lateral to medial side. You have to use a long length because this is deeper block. And the drug is deposited between the facial plane, between the psoas tendon and the bone that is connecting the anterior inferior iliac spine to the iliopectineal eminence. So this is how you perform a needling. So the needle is coming from lateral to medial side, and you can appreciate the psoas tendon, the iliopectineal eminence on the lateral edge of the psoas muscle. Necessarily, you have to give that drug, but as Dr. Gautam was saying, this is a motor sparing when you use the correct volume of the drug. If you use a higher volume of the drug, say 25 mils plus, it necessarily blocks the femoral nerve as well by the intramuscular spread, and it is no more a motor sparing block. So there are few tips and tricks you need to know to call it as a pure motor sparing block. So finally, the last part of THR for the hip, we know the lateral femoral cutaneous. So this is a very superficial, easy block. So just 2 centimeters down to the anterior superior iliac spine, you need to keep your probe in a transverse orientation, and you appreciate the two muscles, the sartorius muscle and the tensor fasciae lata. Just between the two lies a fat-filled tunnel which harbors the LFC and nerve. So you can perform this block even with a hypodermic needle. So as you can see the scanning, this is your sartorius muscle, this is your tensor fasciae lata, and here is your fat-filled triangular space which harbors. So many a times you might not see the nerve individually, but you're depositing in this plane will block these two nerves. So next, coming to the second part of the discussion, the RA strategy for total knee replacement. Again, the lady is talking like, I want a complete pain relief in the post-op, and you have to have the power of a proactive pain management. So first, to learn about TKR, what is your plan and what all we need? We need to know what are the surgical steps in TKR. So what they basically do 5 steps. First is the medial peripatellar incision. So you kindly note the term medial because as we plan for an analgesia, we need to focus more on the medial side of the knee. Second is the medial arthrotomy. Third is the medial dissection, and then they will excise these soft tissues, the cruciate ligament and the menisci, and finally they will go for a tibial and the femoral osteotomy to give the proper shape to the bone for the knee prosthesis. So as again the repetition, if you wish, you should know where the maximum nociceptors are located. So the mainly it is because of the anterior knee. So there is a very good concept here. So if the patient has come to you and the patient is in pain, like an osteoarthritis knee, the maximum nociceptors are in the intra-articular, then in the posterior, and then the anterior. But if the patient has undergone a total knee replacement, post-surgery, the maximum pain will be from the anterior, then the intra-articular, then the posterior. So for us, anterior knee capsule is most important, though we should not ignore the posterior as well. So the pain generators are from the skin, subcutaneous tissue, the incisional area, medial retinaculum, the periosteal rim, and the remnant of the anterior joint capsular pain, and the microfractures and inflammation. Coming to the dermatomal supply, the dermatomal supply is primarily by the anterior cutaneous nerve or femoral nerve, which again branch into two, the intermediate and the medial cutaneous nerve of the femoral nerve, and the saphenous nerve. Of the two, maximum supply is by the anterior cutaneous nerve of the femoral nerve. Coming to the osteotomal supply, it is by the saphenous, obturator, sciatic, common peroneal, and the tibial. The myotomal is mostly by the femoral, obturator, and sciatic. So if you divide your knee into four as a superomedial, superolateral, inferomedial, and infralateral. The superomedial is mainly supplied by nerve to vastus intermedius, nerve to vastus medialis, and superomedial genicular nerve. Friends, all the three nerves are necessarily the branch from the femoral nerve. So if you are targeting the main femoral nerve, necessarily all these individual nerve blocks are not needed. Coming to the superolateral portion, it is mainly supplied by the uh, nerve to vastus lateralis, nerve to vastus intermedius, the lateral branch, the common fibular nerve, and the superolateral genicular nerve. Among here, the nerve to vastus lateralis and vastus intermedius are branch from the femoral nerve, and the later two, superolateral genicular nerve, in few literature they have given it's a branch from the sciatic nerve or from the common peroneal nerve. So coming to the infralateral, they are branches from the infralateral genicular nerve and the recurrent fibular nerve, and on the inferomedial it is the saphenous nerve and the inferomedial genicular nerve. This slide looks a bit heavy, so if I want to block, the most important nerve is the nerve to vastus medialis and the saphenous. The most important maximum nerve supply is by the nerve to vastus medialis than the saphenous. So you should take this point into account while we are planning our strategy in our next slides. Coming to the posterior. Posterior is by the popliteal plexus and the articular branches, which is formed by the articular branches from the tibial nerve, the common peroneal nerve, and the posterior division of the obturator nerve. This is also important because if you're only taking care of the anterior knee capsule, the patient can still complain of the posterior knee pain. So now it's time to plan the analgesia for TKR. So my first plan as a beginner or as a postgraduate, it will go definitely with a femoral nerve block plus an IPAC block to take care of the posterior knee capsule pain. Because in our setup, even in the setup where I am working, generally the patient is not discharged on day 0, unlike in Western culture. So definitely we keep the patient for 24 to 48 hours, and after 24 hours we start our ambulation. So you need not worry too much about the motor involvement part. However, this might differs from place to place. As per me, my first plan will go with the femoral nerve block plus the IPAC block. If you are very much concerned about the motor sparing effect and you want early ambulation and active physiotherapy immediately in the post-operative period, then you can either choose a adductor canal block plus IPAC block or a distal femoral triangle block plus IPAC block. And plan C are mostly the reserve block, though Prospect has also given the intrathecal morphine as efficacious as your single shot adductor canal block. You can go for epidural, continuous epidural, and lumbar plexus block. So as we have already discussed in detail about the femoral nerve block, I'm not going into the detail. However, again, I would repeat, this is my plan A block. So here you need to know a bit importance of the femoral nerve anatomy. Femoral nerve has two divisions, the anterior division and the posterior division. The anterior division is important, as I already mentioned, the anterior femoral cutaneous nerve, which again has two branches, the intermediate and the medial, comes from the anterior division of the femoral nerve. So when the femoral nerve descends, the first division that comes out is among the cutaneous nerve is the intermediate, and if you go distal at the apex of the femoral triangle, it comes at the medial cutaneous nerve. The posterior division, whatever we mentioned, nerve to vastus, medialis, intermedius, lateralis, this all are given by the posterior division of the femoral nerve. Saphenous is also a posterior division of the femoral nerve. So if I ask, you want an absolute motor sparing, then if I ask whether you want to go for an adductor canal block or a distal femoral block, so how do you decide on that? For that, you need to learn what is actually adductor canal. So if you join a line, joining the anterior superior iliac spine to the pubic tubercle, it becomes your inguinal ligament. So if you wish to draw a triangle where the medial border of the adductor longus meets the medial border of the sartorius, the bigger triangle is your femoral triangle. And you further draw a small triangle where the lateral border of the adductor longus meets the medial border of the sartorius. The small blue color line is your iliopectinal fossa. So if you are trying to block so proximal, it is necessarily blocking the femoral nerve. And if you're blocking from somewhere between the apex of the iliopectinal fossa to the apex of the femoral triangle, that is a distal femoral triangle. So this is your femoral triangle block. As you further move distally, so here further, like if you go distal to the apex of the femoral triangle, here starts your adductor canal. So necessarily this is the sartorius, this is the adductor longus. Where do they meet? So if you go 3 centimeter up, it is your femoral triangle block. If you come like go distal or chorded 2 to 3 centimeter down, it becomes your adductor canal. So depending on if you are very close to the junction, it is called as a distal femoral triangle. If you go proximal towards the iliopectinal fossa, it becomes a proximal adductor canal. If you are going again down, if you are close to this line, it becomes a proximal adductor canal, and if you are near to the place, to the adductor hiatus where the genicular artery is going deep, that becomes your distal adductor canal. So this nomenclature has given according to the place where you are placing your probe and where you're injecting your drug. The crux of this is, as you're going more distally, you're going moving away from the femoral nerve, so you will get the motor sparing effect. At the same time, the cutaneous nerves, as I already mentioned, the intermediate and the medial cutaneous nerve, they will take a branch from quite a proximal part. Like the intermediate branch will take a dive somewhere from near to the iliopectinal fossa, and the medial branch will take somewhere near to the apex of the femoral triangle. So if you go too distally, you will miss the cutaneous nerves. If you go more proximally, you will have the motor effect of the femur. The quadriceps weakness will come up. So first I will discuss about the adductor canal block. So if you place your probe somewhere between the patella and between the anterior superior iliac spine, just the midpoint, it is near the apex of the femoral triangle. So if you go a bit distally, it is your adductor canal. So you can see the probe position, just focus on the probe position 1. So if this is the mid thigh, so you have gone a bit distally, what you will appreciate, as I've already mentioned, where the medial part of the sartorius meets the medial part of the adductor longus, that is the apex of the femoral triangle or start of the adductor canal. If you go a bit distal, you will appreciate the saphenous nerve. So in adductor canal block, we are targeting only the saphenous nerve. So if you want to give adductor canal, here you have to take a note that the nerve to vastus medialis lies in a separate compartment. Again, this is one hypothetical thing. Maybe new theories will come up in future. What to the current understanding based on the cadaveric studies, there is a vasoadductor membrane which will keep the saphenous nerve in the adductor canal and the nerve to vastus medialis above it. So if you are doing adductor canal block, you are only targeting the saphenous nerve and maybe this few cutaneous branch, that is your posterior division of the medial cutaneous nerve of the femoral nerve. So you have to perform a separate injection for the nerve to vastus medialis. So what I was talking you about, so this is the figure of 3 where the medial border of the sartorius meets the medial border of the adductor longus. This is called as the kissing sign or the figure of 3. Once you find this, this is the apex of the femoral triangle or the start of the adductor canal. So once you move your probe towards laterally, so this side is your vastus medialis. So you can see I'm doing an in-plane from lateral to medial, and this is my saphenous nerve. So the needle is coming from lateral to medial. Again, since it is near to the vessel, you need to have a negative aspiration always. Go for slow injection technique, and you can appreciate the nerve clearly floating out. Again, I'm trying to inject between in the subsartorial compartment, which harbors the anterior division of the obturator nerve as well as the posterior division of the medial cutaneous nerve, which has least importance in TKR though. So you can appreciate here, this is nerve to vastus medialis and this is your saphenous nerve. As you are injecting the drug, you can appreciate the nerve floating. So many a times, especially in elderly, it is not very clearly visible. As soon as you give the drug, you will see the nerve floating up. So for the posterior knee, so for the posterior knee, we have two options. One is local infiltration of anesthesia or the IPAC. As I've already mentioned, the popliteal plexus is made from the three main nerves, the peroneal nerve, the tibial nerve, and the posterior division of the obturator nerve. So we have to also take care of the posterior knee capsule pain. LIA is done by the surgeon. IPAC is a new terminology which was introduced by Dr. Sanjay Sinha, and it is an Indian, and it means the full acronym stands for the infiltration of local anesthetic between the popliteal artery and the capsule of the knee. So it's a selective blockade of for the innervation of the posterior knee joint. It spares the main trunk of the tibial and the common peroneal, and it maintains the sensory motor function of the leg and the hip. So here, this already I have discussed. It will block the three nerves, mainly the articular branch of the tibial nerve, the articular branch of the obturator nerve, the posterior division, and the posterior branch of the common peroneal nerve. So actually, it travels in a space between the artery and the femur. So that's why it's called as a capsule of the knee and the popliteal artery. So here there are two. The original author had described the distal one, and now the same author has described the proximal one as well. I will be discussing the proximal one. So the patient will lie in the supine position with a slight flexion at the knee and abduction to get a frog leg position. It's a deeper block, so you need to use a curvilinear probe, and then once you place your probe in a position, as I've already mentioned, even you can keep the patient lie supine with with the knee flexed as shown in the figure, and you keep your probe just above the tubal tuberosity, and you will appreciate the femur, you will appreciate the popliteal vessels, and you have to simply, it's a deeper block. Again, I say that's why we are using a curvilinear probe. You have to place your local anesthetic between the vessel and the capsule of the femur. You have to be quite lateral. You need not go to medial, else again it can involve the common peroneal nerve. So this is how we perform. So this is the first position. So when you are placing your probe in the first position, what you appreciate is the femur, the vastus medialis, the sartorius, and then you place your position in position number 2. Again, you appreciate the popliteal artery here, the femur here, and again when you go a bit, if you put the color Doppler, you can also appreciate the femur popliteal vessel, and then you move up further distal where you appreciate the artery, again the femoral nerve, and you may not appreciate the plexus per se, but you will find a space between the popliteal artery and the femur. So here you have to put so you can see the needling as well. So you can appreciate the femur here, the popliteal vessels. So this is the anterior, this is the posterior. Here medial to lateral needling is done. So you can appreciate, since it's a deeper block, you might not need the entire tract of the needle, but you have to park your needle between the vessel and the capsule of the femur. And with negative aspiration, you have to give 15 to 20 mL of 0.2% ropivacaine or 0.25% levobupivacaine. You can appreciate the spread as well. You can see the vessel moving posteriorly. So thank you. If you have any queries or anything you wish to ask, we can take up all the questions at the end of the presentations. Over to you, Murali sir.
Yeah, Amrita, thanks a lot. That was a proper master class in hip and knee arthroplasty and all the techniques. I'm sure the recording will be available on YouTube and people can go back and forth to ensure that they get the concepts really clear. Thanks a lot. So we move over to the next topic, which is concentrating mainly on the sciatic nerve. So Archana will take us through the various approaches to sciatic nerve and also highlighting the importance of sciatic nerve when it comes to the ankle area, because that predominantly supplies the ankle. So over to you, Archana.
Yes, thank you so much, sir. And it's such an honor to follow such beautiful talks already. And I think I'm at the distal end of it now. And we're talking about the posterior compartment and then the ankle. First of all, thank you, Meenakshi Sundaram sir, for that lovely and very first of my time kind of introduction. And also thank you to the entire team for having me here today. And Murali sir also for thinking of me to do this particular talk. So when given the option, I did select to do the sciatic nerve block because this is one of my favorite blocks. It's very close to my heart. I do this day in, day out. I love teaching this block. It's one of those very visual and maybe not too complicated kind of blocks. Not that much debate over when it needs to be used, what it needs to be used for. So it's pretty straightforward. And let's just see how I'll just take you through how I do it, how it can be done, what needs to be done when it comes to ultrasound guided sciatic nerve blocks. So this is where I'm from Coimbatore. As sir has already told, we're in 3 different places, pan-India. I'm from Coimbatore and I work at the Medical College of the Kovai Medical Health Center. So it's a very nice privilege to be here and it's a very lovely weather in Coimbatore. I invite any one of you to please come and do visit this place. Okay. So with that, today, the outline of my topic is basically, we're just gonna, I promise you, I'm not going to go through everything already that Dr. Goutham has. It's just a refresher, maybe just to keep it more in perspective in terms of sacral plexus and sciatic nerve and its approaches. And then just maybe give you a few indications where it can be done. I will show you through the course of my topic and presentation, where and all I have used it and how I found it to be very helpful. I mean, this has been not just a game changer, but for me in terms of understanding, managing emergency cases, all your septic foots, it's really been eye-opening for me during the course of my, the SR ship and everything. So I'll also go through the different approaches very briefly. I'll touch upon all the approaches, but mainly today, my aim is to focus on the popliteal approach to the sciatic nerve block. So that is where we'll be spending most of our time. I'll talk most about the description, the drug deposition point, which LA to use, and how you can assess outcomes and improve maybe outcomes for sciatic nerve block. So this block is not that complicated. It's a good one to learn. It is definitely your plan A, plan B, and plan C block whenever it comes to anything below the knee, basically. So the basic anatomy, now this also already Dr. Goutham has gone through what's the formation of it. I'm not going to focus here. What I'm going to show you is basically a relative anatomy of where it is, okay? So the once it forms, it comes through the greater sciatic notch, the sciatic foramen, as we know, then it travels down into the gluteus maximus muscle close to the, bony elements on either side. And then as it courses down into the lower limb, so here it has its muscle planes through which it goes to, and it accompanies, of course, the major blood vessels supplying the lower limb. So the sciatic nerve, as we all know, it is the longest nerve of the body, and it is one of the major, supply of the limb below the knee, especially, okay, the foot, the ankle, in conjunction with the femoral nerve. So this is just a brief outline and what is the course. And then finally, it terminates into its 4 branches. So you have the sural, the posterior tibial, you have the common peroneal, which again divides into the superficial and the deep peroneal nerves. Okay, this is exclusively, I'm just talking about the sciatic aspect in the ankle. Okay. So indications are below any surgery below the knee. And I know you can see this picture. This is pretty much the one surgery that it is indicated in all or any kind of your septic foots. But again, I want to stress here that any surgery, even if you're doing it below the knee, do the block, yes, but then always assess the block before you hand it over to the surgeon, so that the surgical site needs to be assessed. In that case, most of the time, almost 99% of the time, you might need a saphenous nerve block as well. So that already the approaches have been covered. You know how to do it because you're doing it for the hip and the knee, as already Dr. Amrita has mentioned to all of us. So this way, you use it in addition to those techniques, and then only you can do only under blocks, nerve blocks, that is the ankle or the any surgery below the knee. Okay, so even a tendo Achilles repair, all these sort of things, it offers a benefit too. Definitely regional anesthesia and the peripheral nerve blocks when you have the very sick septic patients. I remember the very first night duty I did as a senior resident. I had a surgical SR coming and telling me, madam, this patient has sodium of 120 and DKA and all these sort of problems, but it's all because of sepsis. I need to control the sepsis. I need to take out the focus. And of course, that's the foot. And at that time, this is before I did my fellowship, so I was not well versed with the block. So I said, so I have to consult my senior, and my senior said, no, you have to optimize, then only I can take because you're in acidosis. But then it's logical. The sepsis is not going to correct itself unless, we push it, we try to do a proper source control. So now I have SRs here that call me up and say, oh, madam, we've done this debridement. And then the next day they say, oh, but the cardiac evaluation was the ejection fraction is only 10%, or the anemia, the HB was only 8. But, these patients have survived. They've at least done a source control. They've gone in and they've, had their antibiotics and the dressings, and now they're doing pretty fine. So that is where the game has changed, when you can do an ultrasound guided, a properly performed block. Okay. So the different approaches, anywhere from the plexus to the distal nerves in the ankle, it can be approached. You can visualize these now with ultrasound. Maybe before ultrasound, it was a little more challenging. You had a lot of loss of resistance techniques or landmark-based techniques. But now, because of ultrasound and also the assistance of PNS, using landmarks, you can do it anywhere in the lower limb. It can be approached. So just quickly going through the more challenging blocks, these are more of a level 3 intermediate to advanced level blocks. And most of the time, so I didn't even start doing sacral plexus block till about 5 years ago, when I actually found that there was more of a need sometimes. But definitely, if done well and done right, it can also give you complete anesthesia of the lower limb along with your lumbar plexus as well. Okay. So basically, the sacral plexus is higher up. You're targeting the sacral, the greater sciatic foramen, the notch, and you do basically it's a parasacral approach. It's a deep approach. It's a difficult approach. Okay, there's a lot of muscles in there. It's quite challenging to do in obese. So this is where you mostly have to use the curvilinear probe just to get it. And most often the depth, even in the thinnest of individuals, sometimes it's almost 6 centimeters of depth. So there are also lots of vessels around there that you have to be very careful for. So these deep blocks you will not do, obviously, if you have and issues with coagulation and anticoagulation and antiplatelets. Okay, you do this and you're starting out, you start doing it with the dual guidance technique so that it'll help you to identify the nerves better. So if you can see the first probe position allows you to scan the bone, and you're scanning above the ilium. But then once you just slide the probe down, as you can see here, so we start this is probe position 1. You see the continuous ilium will be there. You see the muscles on the gluteus on above the ilium. And then as you slide the probe down, you'll see that this continuous white line, it will break, and then it will open up to the piriformis muscle. Underneath that, you will be able to see the plexus. Okay, so this is easily scanned, but not easily performed. Okay, so you need to practice a lot before you get to this stage. However, when done, it can completely anesthetize the sacral plexus, the part and wherever it supplies in the lower limb. So this is essential maybe when you need to do lower limb surgeries, when they need to do a tourniquet, when they require a tourniquet. So the tourniquet pain can only be taken care of by the sacral plexus block for the posterior aspect, that is the hamstrings. The anterior aspect will be taken care by either your femoral nerve and the obturator nerve, but the posterior, the hamstrings, the branches of them directly come in from the sacral plexus. And this is why a sciatic or even a subgluteal sciatic might not be enough to cover if you're using or planning to use a tourniquet in the lower limb. So exclusively, this is the only one that is almost foolproof if you can get it, have it performed properly, where you can use a tourniquet. Okay, the next difficult block, but sometimes it might be necessary where you might not be able to position your patient because generally the sciatic is approached lateral or in prone. The only approach that again also uses a curvilinear probe, but again, it is quite deep, it is quite challenging. It is the anterior approach to the sciatic nerve. You can see this individual was not even 50 kilograms but muscular. So you can see that it was quite deep here. This is the femur, okay? And from the anterior aspect, you see the sartorius, then you see the adductor muscles, and then between the adductor muscles, medial compartment and the posterior compartment, that is the hamstrings, you can see it sandwiched quite readily here. And then even if you have to come through any which way, this way you come through, it will come through the bone. This way you might contact the artery. So it's quite challenging. Again, this is not for the beginners. So then from anywhere, the infragluteal or the subgluteal, you can approach again the sciatic nerve. So from now onwards, the plexus branches have been given off. And the major components now that you are dealing with are the common peroneal and the posterior tibial, which both of them are together. And studies have shown, and anatomy dissections have shown, that these both are separated right from the beginning. It is just that they are traveling along their course in one single plane. And by the time they reach the popliteal fossa is when they tend to divide. And then along the way, the branches are being given off. Okay. So after the popliteal fossa, except for the sural nerve, which is quite variable and can happen sometimes above also, the main terminal branching happens after the popliteal fossa. So that is why the popliteal fossa is it's a simple way to do a single injection and just get 4 or 5 nerves to be blocked for your surgical anesthesia or analgesia purposes. So the infragluteal or the subgluteal is accessed, as you can see, just at below the cleft. And here, basically, what you're looking at is from the superficial, it's the gluteus maximus. Then you are above the quadratus femoris. In between the bony landmarks here are the ischial spine and the femur, basically, the greater trochanter of the femur. So, but here what happens, again, this is a deep block. So you need to use a curvilinear probe. And even though the fortunate thing about the sciatic nerve is that when you scan it, it's the brightest thing that's on the screen and usually in the center of your screen, especially when coming in contrast with the muscles and the tendons. The way you can differentiate these as the nerve and not being the muscles or the tendon is that if you scan to and fro, the tendons will not be continuous. The muscle fibers will be, quite scattered and may not, it will be interrupted. But whereas a nerve will be continuous, and even if you scan it in the sagittal, you cut it in the sagittal, it will be continuous and you'll see it as nice line fibers. Okay, so the other thing is that you have to remember sciatic nerve, it's not perfect round as we expect or, as anything we want it to be. It exhibits anisotropy, which means that even if you just lose your angle tilting a little bit, you can still lose visualization. So if you know you're in the right place and you're scanning, your probe is in the right place, please just try to tilt it a little bit, either up cephalad or caudad, And usually that will give you the bright honeycomb appearance, and you should be able to identify it fairly easily. Okay, so that's about the anterior approach. Now, getting into the one and the approach that I wanted to focus on today, that is the popliteal approach to the sciatic nerve. So, as it is in the terminology, we are approaching it at the popliteal fossa. Okay, there are again two probe positions that we need to understand when it comes to performance of block at this area. So what are those probe positions? One is in the fossa itself, and there that it depends on you identifying the important structures first. First you go, and the easy ones to identify is the vascular structures. The artery will be pulsating, the popliteal vein will be compressible. So once you identify these, usually the nerve is superficial to it. Okay, so you interchange between these two positions in order to confirm the presence of the nerve. And basically what you're looking for is the clinching factor, or the very much identification for this approach is the popliteal bifurcation. When the sciatic, the common peroneal and the posterior tibial, they separate from each other, and that is the point of bifurcation which we look for. Okay, so that's a very objective endpoint when it comes to the popliteal approach of the sciatic nerve block. So the scanning here, as you can see, it's usually quite superficial. Even in the most obese individuals, the popliteal fossa usually tends to give way. Unless it is too deep, then you need to use a curvilinear probe. Otherwise, most of the times we can get away with using the high frequency linear probe. And of course, we all know the higher the frequency, the better the resolution, which just means that you can much more easily identify structures much better. Okay, so patient positioning usually, so if your patient can allow it, the most ergonomic and comfortable way to do it is in doing it in prone, especially if you're starting out. Okay, if it's not possible, then lateral also is okay. If lateral is also not possible, then you can go into supine with a limb elevation. But at that time, you need to recognize that your images can get switched over. So the orientation. So as you move from prone to supine, it becomes challenging to identify structures. So again, the prone and the lateral are the easier ones. The supine with the limb elevation is a little more difficult and challenging to do. Okay, so in prone, you can see in this image here, this is essentially what it will look like. The sciatic nerve will come down, and then enter popliteal fossa. At some point, it will, bifurcate. Okay, and we're going to use the high frequency linear probe. Okay, so probe position 1, once you place it on the top of the, at the top or the crease of the popliteal fossa, the first thing you're going to try and identify are these vessels. So you can see here the popliteal artery and the popliteal vein. Okay, and then just above it, if you just start tilting a little bit, you'll be able to see this bright honeycomb appearance, which is the sciatic nerve. Okay, now I want you to appreciate not just the sciatic nerve and the vessels, but also on either side, you see there are muscles. So it's very easy for you to confuse the nerve with the muscles. Okay, on the medial aspect, you'll have the biceps femoris, and then the lateral aspect, you'll have the biceps femoris, and then the medial aspect, you'll have the semimembranosus and the semitendinosus. Okay, at the base of the popliteal fossa, you'll have the posterior aspect of the femur. Now, this already Dr. Amrita has told us when she was discussed about the IPAC block. Okay, so essentially this is what it is. And so once you identify these, you just have to scan up and down. So move between, slide up, slide down a couple of centimeters till you can see that these two separate. Okay, and I'll show you a quick video in the next coming slide. So just remember this image and remember the orientation of the sonoanatomy. So you will see that one nerve just takes off and goes laterally towards the superficial structures, and then one nerve or aspect stays along with the vessels. Okay, so let me just show you here. Yeah, so here you can see in the center of the screen, there's the vein, there's the artery. You see this has now split into two. One is staying close and staying put with the vessel. The other one is moving laterally. So this is going forward and now coming back to join again. Okay, Again, I am scanning back down distally. You can see that they're splitting. So the one which is going this way, okay, is the common peroneal nerve because it's going superficial, okay, and laterally. So by that, I know my probe marker. I keep my probe marker laterally so that I know if the nerve is moving towards it, it's the common peroneal nerve. The posterior tibial nerve is the one that stays close with the vessels and it travels down into its course along with the vessels and then splits into its different branches as it goes down through the muscle layer below the knee. You can also see, but this is not always possible, the small little hyperechoic thing. So this is basically the sural nerve in this particular individual. So it's probably come out higher for him, but you can look at it. But for now, what I want you to always try to identify is the vessels, the muscles on either side. You find the bifurcation and then you scan up and down dynamically couple of times so that you can animate the nerve as it bifurcates. And this makes it easier for us to identify. Okay, as you can see, it's continuous, whereas the muscle is not continuous. It stays, it's just got an interrupted kind of pattern, but the nerve is consistent, it is straight, it is just moving to and fro. Okay, so that is the identification of the popliteal sciatic approach. Remember, identify the vessels, then the bifurcation. Okay. Okay. So now again, this is just a same video. Let's go to the next one. So when it comes to needling, we can do it both in plane, which is what is suggested for beginners, especially when you're starting out, so that you can envision the needle in its entire length and be sure where the tip is. Okay. Another school of thought is to do it out of plane. Why out of plane? Because when you're going out of plane, you are going in line with the sciatic nerve so that when you give the drug, you are the spread will be along the nerve rather than either on the either side in case you miss the plane that you need to be in. So either way you can perform it. If you're a beginner, I suggest you please go ahead with the in-plane approach and be very careful to visualize where your needle tip is at all times before, so to ensure that you are not, as you could see, the popliteal vessels are just below the nerve. So you need to really avoid puncturing them at any cost. Okay. So where now do you deposit the drug? So when you're doing the block, yes. So you can see beautifully the needle is there and it's going towards the nerve. You can see that the common peroneal aspect is over here and the posterior tibial is over here. Even though they are separate, they are contained in one kind of a sheath. Okay. So the object is to get the needle tip just to breach that outer layer of the sheath and then deposit the drug there. Okay, so this is yeah, a little bit ideal. They're giving a little bit of drug a little bit at a time and ensuring that the drug is spreading in the right place. Now, can you also see that drug is spreading in this muscle plane? So when you're seeing this, please try to reposition the needle as they are doing here so that you ensure that you're not depositing your drug in the muscle, because most of the time, and I'll show you why in just a moment, these are the reasons for your failure or patchy block when doing especially a sciatic nerve block. Okay, so that's purposely why I put this video. Yes, you do it in plane, but make sure it's not spreading in the muscle and that it is spreading along the nerve. Okay, so I'll just show you what I mean. So this is one which I have done in an out of plane technique. You can see this is the needle tip here, and this is the sheath. This is the muscle outside. This is the nerve. This is the common peroneal nerve. This is the posterior tibial nerve. As they separate, you can just see that. And then you've deposited drug and it's given a nice halo or a donut sign. And then as I scan down, I can see that it's all spread. You can see the sural nerve here as well. But you see that it's nice and separate, but it's nice and donut and it's not inside too much of the muscle plane. So one advice here can be that when you're initially doing the block, you can possibly, instead of directly injecting a local anesthetic, possibly you can go ahead and just do some hydrodissection so that you can, just a small aliquot of like 0.1 or 0.2 ml, and that could possibly help you delineate the sheath where you need to be in order to get a successful block. And then once you identify the right plane, then you can deposit the local anesthetic so that you're using the maximum you're not wasting your local anesthetic into the muscle planes. Okay, that's just one pearl that can help you out here. So why this drug deposition point? Why not just surround the drug? As you can see, when I breach the sheath, it's just spreading all around without me not having to manipulate my needle around the nerve. It's a single point injection, single point drug deposition that is giving me such a beautiful and wonderful spread. Okay. So why does this happen and how does this happen? Essentially, this is there for every nerve. But in the sciatic, it is more pronounced because it's a very huge nerve and you have two separate nerves in one compartment where at one point in time they bifurcate, but they're still in one compartment. So essentially the neural elements push to the side, and in between that you have a very clear cleavage plane in order to deposit the drug. Okay, and I'll just show you what it is by illustrating this anatomy of a peripheral nerve. Okay, so just to get back to your basics, we have each of these axons and nerves have their fascicles, which is surrounded by endoneurium. Then these fascicles join together, all right, and they're surrounded now in perineurium. These separate sets of axons now come together and they all form the peripheral nerve, and they are surrounded by they are embedded inside an inner epineurium, and then they are membranized or encircled by the epineurium, right? Now, traditional teaching tells us that anything you breach beyond here is intraneural. You go even more inside the endoneurium, that is intrafascicular, and these are no injections. You should not be doing them. They have a high risk of peripheral nerve injury, especially when you need to do these kind of blocks in patients that have compromised vascular supply in the lower limb and even possibly diabetic neuropathy. So this is something you should be very careful about when you're doing it in these patients, okay? But what happens after this here, especially in the sciatic nerve? So this is what the entire nerve looks like in a 3D way, okay? Now, they are supplied further by more connective tissue layers. That's called the paraneurium, okay? Beyond this now, there are the muscles and the other connective tissue layers, which again, both of them form the epimysium layer, okay? So each layer you come away from the nerve, the more distant away you are, automatically the understanding is that there is more resistance offered to the local anesthetic, and therefore your block is not going to be as potent or as effective as if you did it closer to the nerve. But how close can you go? Basically, the closest that we should go, which is so far been deemed safe by research, is the paraneurium sheath. If you can breach this layer, okay, which is especially so much visible in the popliteal sciatic approach. You can see if you can go in between them and deposit a local anesthetic, you are not considered to be intraneural. In fact, this is called the sweet spot of the nerve. And this is a terminology that we are stealing from the neurologist and the neurosurgeon, the subparaneural compartment, basically, wherein you can be as close to the nerve, but not breach it, and then very less likely of you to cause a peripheral nerve injury, okay? Not only that, this compartment is quite continuous. So this is what is allowing the drug to spread so beautifully around the nerves. And because of the shared compartments and shared tunnels between the common peroneal and the posterior tibial connective tissue, when you're giving it in one, sometimes you can see the spread filling in the other side as well. So that's the beauty of the popliteal approach to the sciatic nerve, okay? So essentially, when I do my sciatic nerves, this is my target. This is where I try to breach, and I try to get into this paraneural layer in order to achieve a adequate success for my block. Okay, right. So don't just take my word for it. This is an excellent article by Dr. Manoj Karmakar, who came up with this concept, and he in detail covers this block and the anatomy and how the anatomy compartments are shared. So I suggest whoever, even if you are a beginner, because it's a very, very easy to understand article as well. So please, if you're venturing onto this block, don't do it before you read this article. It's very useful and very, very well written. Okay. So next, so that is what I mean. If you can see again here, I'm in between the two. This is the common peroneal compartment, and that's the posterior tibial. And then again, we're trying to give a little on either side, possibly because we felt that the spread was not enough. But then you see, once you get into the plane, automatically the spread does happen. How far does the spread go? Okay. So far, when I was, able to be part of one of postgraduate thesis studies, and where they tried to study how much ml and how much distance it travels, there are studies that says in a cadaveric studies, especially when they give dye in the popliteal area, they've seen it in segments in the brain actually. So I don't know if our local anesthetic goes that far. But every time I do scan, so my go-to volume is around 15 to 20 ml, some of the time. And most of the time, 25 centimeters, at least I have a good drug spread from my needle incision. So it's a needle drug deposition. So it can be around 10 centimeters to 20 centimeters above. And also it spreads distally as well. As you can see, this is called the double halo sign or the double donut sign, whichever one it's good. The point is you're seeing drug, not just in the sciatic, but also as it spreads distally and proximally. So this is, in general, you can see how much that ruler is about 15 centimeters. So the spread usually can go up or down any extent. My suggestion would be, once you give the block, scan up and down and see how far it's spread. And that will give you a good indicator of how much length of the nerve is exposed to local anesthetic, giving you a good conduction blockade possibly and a good surgical anesthesia outcome, especially for the popliteal aspect. Okay. So like I said, local anesthetic around volume is 15 to 20 ml. And for surgical anesthesia, when I'm going straight for debridements, I do some combination and permutations based on the patient and the underlying condition. If it's a young patient, no comorbids, and it's a trauma, so it's a fresh trauma, I generally go in with the lignocaine, and sometimes I mix that with the bupivacaine, or I can even go with a plain bupivacaine as well. However, if my sciatic nerve, it's because of a diabetic foot or a vascular compromise, and I just need it for a quick debridement and maybe some analgesia, usually the lignocaine, because already these nerves are susceptible, plain lignocaine itself, sometimes 1 to 1.5% is more than enough for the surgical aspect, and then it gives a good amount of analgesia. But that's basically coming down to the physiology of the nerve. And if you can understand that, sometimes I'm quite sure those people of us who have already been doing the block, when they give in the bupivacaine, sometimes maybe the patients don't recover from the block for at least 48 hours. So then you start to get scared and your surgeon starts blaming you and all these sorts of things happen. But till 48 hours, if a sciatic nerve has not recovered, wait for 48 hours. Give it some time. Usually the underlying, thing, unless there is any other bleeding hematoma or anything, as long as you've ruled that out, then it should be okay. It will recover. But we just need to be patient and very careful, especially in these diabetic neuropathic patients. Okay. So this is just my personal experience with the case I did recently over here. This particular gentleman came in very bad sepsis, very, very bad sepsis. He underwent an initial debridement, and then that is like when he was nearing arrest, because following the surgery, he did arrest. But then they resuscitated him and then gave him good cover and proper support in the ICU. And he could come back at least for a below knee amputation after the initial debridement. But as you can see, the challenge faced here is, yes, his comorbid conditions did not allow us to give a GA, or yes, you can give a GA, but however, you have to be very wary of the complications. If you can avoid it, then that's what we do. If you have to give it, then you go ahead. That's our savior in the storm. But when it comes to something like this, it's quite complicated. And the only indication was not for the revision and the continued debridement, because he continued to have discharge through each of those fasciotomy wounds. He was not allowing them to do proper dressings in the ward also. So we go that extra step sometimes, and we put in sciatic catheters and femoral nerve catheters in order, or even adductor canal catheters, in case the patient is mobile. Obviously, in this particular individual, I don't need to worry about motor sparing. In fact, that will give him a better pain relief and also prevent some sensitization into that phantom limb transition as they're going in, while we do give the multimodal analgesia. So what I did is for him, I did a femoral nerve catheter and a sciatic nerve catheter. I put in a block initially for the surgery, and then I secured catheters. And then because of the location of the fasciotomy wounds, for the OT procedure alone, I have given him a single shot obturator nerve block and a single shot LFCN block. Because I have used ultrasound, you might be wondering, my God, 4 blocks, how much volume did you use? So I used about 10 ml for each of the femoral, the sciatic, and the obturator. But with the LFCN, I just needed around 3 to 4 ml. So that's how much I used in total. And I was able to achieve complete anesthesia of the limb. And I'll show you how I do it. Because as you can see here, there's not that much space to do it in the sciatic region. Okay. So this was my ergonomics. For continuous catheter techniques, we have to use a complete asepsis. I had this patient particularly in prone because I thought I needed the best ergonomics in order to be successful at the block. So only when your ergonomics is right, your success is improved. I've given him oxygen support. I've given him some mild sedation and analgesia with some fentanyl, and of course the full aseptic precautions. And then my assistant also, she has, she's put in the technique. So once I localized, so the advantage with the ultrasound is I couldn't do popliteal scanning because there was full of air. However, I scanned up and more closer, not exactly the infragluteal, but somewhere in the mid thigh, I was able to see it was quite superficial. And I was able to do the procedure. I put in the catheter in an out of plane technique because I wanted to be, that was the best way I could actually achieve it anyways. But in practice, I tried to keep the catheter along the length of the sciatic nerve. And in this video, actually, I've already secured the catheter. So this is the catheter. You can see that little bit of air when we try to push in a test dose. And you see this is the nerve, okay? Because you're more in the mid-thigh, you won't be able to see the bifurcation. But you can see here the local anesthetic spreading around the nerve, and you can see the halo also. So this air, what you're seeing here, that's basically from the catheter. So the catheter, there you can see again, air that is coming through. That has confirmed my position of the catheter tip. And then I was able to go ahead and perform the other blocks and complete his surgery. So once I was done, as you can see, we had the catheter secured. I've pulled up enough length to a place where I can access it in near to the inguinal crease so that it is easy, and I fixed it all off to the side. So it's easier for my, when we go and give the top up. So these are managed in our separate post-op HDUs and all, where are under our supervision. Even so, this is the pain nurse that is coming and giving the top up before doing the dressing of the leg. So this gentleman, with his consent, I've taken his images, and he was very happy. He had the catheter for at least 20 days. And he actually, one of them came out, but then we had to do some convincing and counseling. But now he's doing quite fine. He's had the revision also, and he's been discharged. So these are quite the advantages of doing this block. You can put a catheter. Of course, you need some experience with that, but at least the basic block can actually save a patient's life. At least it can contribute to it to a certain extent. So when to take home, finally, to summarize, any procedure below the knee, in addition to the femoral nerve or the saphenous nerve, the ultrasound has, doing this block has enabled us to do management of very sick septic foots. It needs, however, a very clear understanding and a course of the surgical needs. Your ultrasound contribution is immense. It's increased the success. It has given you clear identification of targets, the subparaneural compartment. It helps you to avoid critical structures. It provides more options and different access size to suit your need, and allows the visualization and spread of local anesthetic to ensure that you are successful. Local anesthetic, it's, give and take. You have to be very careful with your choice and choose it accordingly. So again, I'll end with my favorite sonoanatomy images of the halo or the donut, which is one of my favorite sweet treats when I need to cheat on, my dieting or whatever it is I'm trying to do. So thank you very much for your patient listening. I'll hand it over to Murali sir and Meenakshi Sundaram sir to carry the rest of the session.
Archana, thanks a lot. I think one question that I have is, can you share this as a screenshot to everyone? They can put it as their wallpaper on the phone. It's so beautiful.
Yeah, no.
Especially the tibial and the common, the peroneal
Ah.
and the sural are coming out. I mean to say the sural is not something that we see on a regular basis when we do the block.
Yeah.
And it's so cute that it is coming out on top when you're actually injecting into the paraneural sheath.
And it's so
So,
funny that was taken in 2016 when we weren't even talking about it. And that's the same image. And today we are able to see. That day I didn't see it. Today I'm able to see it. Yeah.
so the eyes will see what the mind knows, right? So that's, I think, where we are heading.
Yes.
Dr.
So I think we
Murali,
have,
Dr.
yes, sir.
Murali, before you open this for discussion, because one question is in the chat box. See,
Yeah.
this we have not interfered because it is already 8. We have not interfered because the YouTube recording, I feel it is going to be the one of the best recording, and it will be viewed by many, because I'm very sure, because for a beginner like me in the ultrasound guided regional block, see, they have analyzed every bit of it. See, that too, the common femoral and tibial, I was thinking, this is just like a boyfriend proposing to the girlfriend, and suddenly there is a breakup. She is adding, she is separating, just like that. She doing this YouTube recording. Definitely, I will post you how many viewers are there. This will be a permanent recording for the Indian standards. It is really good, and I have to thank all the faculties. It is really good. Over to moderator.
Thank you very much. I'm sure it is an international standard presentation. I won't even call it
Sure.
because we have covered most of the things. We'll take a few questions actually, which have come through the chat box. Dr. Archana, it's for you. CAPS block, popliteal block given in a lateral approach with supine position. How is it different technically from prone or lateral approach? And CAPS originates from Coimbatore, so I think you'll be able to answer that.
Yeah, so the cross approach is more, it's one of those deeper approaches. So here we're using the linear probe. There they are using the curvilinear probe. So the resolution comes down a little bit, and it's used in much more challenging situations. So, it's not exactly, so I haven't done it much. I mean, I have never found the indication to do it. Because usually my patients present like this, and I tend not to do something that I haven't tried before. Maybe now is something I should look at it when I'm doing it. But as far as my understanding when I read it is that it's for much more deeper, much more challenging situations when you can't put them in a lateral position, and you're presenting it, the patient is supine, and you're presenting at a cross oblique approach. I think Dr. Amrita, I don't know if she can add to this, whether she's done this before. So, because I haven't, honestly, I've only read it.
Yeah, Dr. Archana, actually, it is an indication when you don't want to do a prone or lateral. But even in my practice, even in the supine, I'm able to negotiate and I'm able to do at the same. But with the lateral, this is in the, as you correctly mentioned, the lateral approach, and here it goes through the muscles. So it's quite a bit deeper. But however, especially when you don't want to do the prone and you're not comfortable in doing a supine, that times it helps.
Yeah.
Again, my experiences were done around 10 or 12, and it was mainly for the academic reason. But as you said, most of the patients will be able to lie lateral. And the other thing which I use is the lithotomy stirrups. So that can be used actually to place the leg in such a way that if the patient is unable to lie prone or lateral, even a supine patient can actually be, the leg can be put on the stirrups and you can do the block.
Yes, sir.
Meenakshi Sundaram, sir, I don't see any other questions coming up here.
Because see, I can tell you, if there are no questions, we used to say one, it is crystal clear, or one, they are not aware. See, actually, this is crystal clear. I'm very crystal clear, and your doubts can be raised by the highly technical people, high techies. They will ask questions. Now, as these are, I think they will go through repeatedly to learn what is what, because at one time you are saying so many muscles, so many nerves, so many blocks, because you want to finish just like a Tejas train. Even then, the train is running late by 30 minutes. But but we have not interfered because it is going to be a permanent record. Why I said Indian standard, the foreign people, they may not listen to us immediately, but in this Indian standard, I will let you know because I am extremely happy the way in which it was conducted there because the faculty are highly skilled people and these three speakers were mouthpieces of Dr. Murali, I think. So he is sitting quietly, just like a brain. He is in the same place, and just like the nerves, these people have taken it to the forwards, and really, we are thrilled and sensitized by this nerve story. So we cannot expect questions really because it is phenomenally well. Because so many ultrasonic images, so many nerves, so many muscles, it is very difficult. I think the beginners, even the practitioners, they will go for a screenshot and they will approach one by one, then only it will be known. So we need not worry about answering the questions. And if the moderator is willing, I can ask our treasurer to propose formal vote of thanks.
Sir, please.
Dr. Hema.
Yes, sir. Good evening, everyone. I thank you all for participating in today's episode on ultrasound guided regional anesthesia for lower limb blocks. I thank our academic chairman, Dr. A.L.M. sir, for guiding us, and thank you all the presenters for making us glued to the monitor. I thank Dr. Goutham Reddy, AORA Fellow, Apollo Specialty Hospital, Bangalore, on the topic on lower limb pain generator. You have given a good anatomy, pain generators of the hip and knee, and relevant regional anesthesia techniques. Thank you, Dr. Goutham Reddy. I thank Dr. Amrita Rath, Associate Professor, IMS, Banaras Hindu University, Varanasi. Ma'am, you give thanks to all the strategies on video with videographic representation on the hip and knee replacements. Thank you, ma'am. I thank Dr. Archana Areti, Associate Professor, KMCH Institute of Health Sciences. Madam, on your topic with research and detailed presentation on anatomy, USGRA approach to sciatic nerve, techniques, and drug deposition and outcome. Thank you for the presentation. Thank you, ma'am. I thank our moderator, Dr. Murali Thondebhavi, sir, Senior Consultant, Apollo Hospitals, Bangalore. I thank Clarinet for your continuous support, and I finally thank all the postgraduates, colleagues, consultants for continuously supporting us in the increasing numbers. Thank you all. Thank you. Good evening.
Thank you, Dr. Hema. I request the
Thank you.
clarinet to concluding remarks and close the session.
So, thank you so much to all the dignitaries present today, and I would like to thank everyone for your continuous supporting. And Clarence is really glad to have you in our platform. So, with all your due permission, we can conclude the session in here for today, and looking forward to host you again. Thank you so much. Good night.
Good night.
Thank you.
Good night.